Thank you. Good afternoon, everyone. My name is Keelan Murphy. I am the TRIL Communications Manager. I'm based in Dublin, in Ireland. The Technology Research for Independent Living Centre is a virtual centre based in Dublin. We are looking at the physical, cognitive and social consequences of ageing and looking at developing technologies to address those. So today I'm going to introduce you to the TRIL Centre, talk about how we are developing our technologies and bringing them from a clinical and lab environment into the homes of older people. The fact that the world is ageing is not news. The fact that there are going to be more people over 65 than children in many countries very soon is also not news. But last week in the UK, for the first time ever, the number of people over 65 is now more than the number of children under 5. The old portion of the population is also growing, i.e. the over 85s, that's increasing fastest. And basically, in the next 40 years, we're going to explode from 673 million older people, or 10% of the population, to 21% of the population at 2 billion. So we should be proud of our rise in life expectancy in the 21st century. 1 in 4 of us born today will live to be 100. And in fact, if you're female, you're even luckier. 1 in 2 will live to be 100 if you're born today. Yes, we're better than the men in this area. However, longer lives do mean longer periods of ill health, obviously. And the key issues for older people in particular are falls, social connection and cognitive decline, the so-called geriatric giants. Half of the emergency department admissions are due to falls in older people. Half of hip fractures, people who suffer from hip fractures, never actually regain full function. And 1 in 5 of those actually die in the first 3 months of fracturing their hip. From a social point of view, the health risks associated with lower levels of social integration are comparable to the health risks associated with cigarette smoking, high blood pressure and obesity. One of the biggest limiting factors to independence for older people is due to impaired cognitive function and its consequences. So in other words, accident proneness, for example, falls, burning themselves, bruising, cuts, self-neglect, for example, mismedication, poor nutrition, poor hygiene, loss of initiative, diminished repertoire of activities and low mood. And as the population is ageing, the dependence ratios are shrinking. So when pensions were first introduced in the UK in the early 1900s, there were 22 people working for every retired person. However, in just over 14 years, there will be less than 3 people. The changing nature of this fiscal base lowers the economic output and hence funding for the health and social care. So also we can rely less on the informal care of older people by friends and family. As our first speaker, Dr. Davini, was saying, health and social care systems globally are immensely challenged by the current demographics and health profiles. We need to start rethinking how our healthcare is both configured and delivered. The current model is unsustainable. So at the centre of TRIL's ethos is home and user-centred delivery of care. Homes are symbols of independence for older people. They're a demonstration of their competency. They're where people want to live as they age. They are currently central to Western policies of care for ageing populations because homes have positive associations and meanings for everyone, and there's a growing recognition of the therapeutic benefits of delivering healthcare in the home. The trend is moving away from institutional care, as the 2 previous speakers mentioned, and bringing healthcare to the home. And we're recognising that home care is most likely cheaper and more personalised, and we feel technology has a key role to play in delivering this vision. And hence TRIL, the Technology Research for Independent Living Centre. We were established in 2007. Our partners are 3 universities in Ireland: Trinity College Dublin, University College Dublin and National University of Ireland Galway, and 2 industry partners, Intel and GE Healthcare. We're funded by Intel, GE Healthcare and the Irish Government, the IDA Ireland. We are an applied research centre. We are hands-on. We have 4 labs and a clinic. We're engaging with older people in their homes and their communities. We are a real industry academic collaboration. The industry partners are not just sponsors, they are fully active in the research group, and we're all coming together to reimagine and reinvent ways of meeting the global ageing demands. Our research is clinically informed. We have a clinic, which I'll tell you all about in a moment. So our clinical assessments are, generally clinical assessments are rarely part of a centre like this, but we have a unique data set that we've captured from our clinic, which provides clinical input and validity to our technology development. In other words, we've got clinical pull rather than technology push. We're multidisciplinary. We have a large clinical data set, as I said, and we've got a huge quantitative output from our biopsychosocial assessments. So, as I said, our team is multidisciplinary. We've got somebody from each of those areas, which is very unusual, and they are all working together in harmony, which is very nice and unusual. As I said, we have a clinic. We have the TRIL clinic based in St James's Hospital, which is the largest hospital in Dublin. The clinic was set up in August 2007 to deliver physical, psychosocial and cognitive assessments which are aligned to our 3 areas of fault prevention, social connection and cognitive function. To date, we've assessed over 600 participants, all over the age of 60. We received an ICT award from the Irish Healthcare Awards for Best Use of ICT in 2008. Through our novel assessments and technology, we're promoting the clinic as a model of early intervention clinic. So we've identified a number of underlying health conditions in our participants. We call them the walking well, who didn't know they had underlying conditions when they came to see us first, and we referred them on to GPs or appropriate centres within St James's Hospital. They've been dealt with early, and as a result there's a huge benefit to both the participants themselves and the cost to the healthcare system. And this year, 2010, we're starting follow-up longitudinal studies on 300 of our original 600 cohort to gain better insight into the ageing process. Observing people in their natural habitat by using ethnography in technology can help identify what people find difficult, what would assist people day to day, and how can people's needs be supported by devices. Ethnography uses anthropological and observational techniques to assess what people really need and would a product find mass acceptance. The philosophical foundation of ethnography for the TRIL Centre research programme is ethnography. Our research must have real-world impact. It must change people's lives for the better. It must have value, and it must have application beyond the lab. Our ethnographers ensure that the voices and concerns of older people are at the centre of the TRIL Research Centre programme. We use an iterative design development life cycle to create our technologies, as you can see here. We look at the clinical requirements and we identify specific conditions that we're looking to measure. We then identify specific parameters and levels that can be assessed, develop an engineering requirements document, and then through a process of discover, design and evaluate, design our technologies. As I mentioned, we're working on 3 of the 3 so-called geriatric giants, but because of time constraints, I'm just going to focus on social connection, just very briefly. So social connection is a key determinant of health, quality of life and mortality in older people. Social connections can fail for a number of reasons. A partner may die, friends may die, or an older person may move from their original place of living to move in with their families if they need more care, and hence lose their social network. We're looking to increase understanding of the relationship between social relationships and health. Can we see how technology might decrease health risks associated with isolation, loneliness and loss of social network? And our main questions, the cause for causality, are: is it network, loneliness or isolation that impacts on health and happiness? And does intervention make a difference? So rather than talk through the next slide, I have hopefully a video for you. Hopefully the sound works as well.
Which is hosted on a server and which manages all broadcasts and communications between building bridges devices. It also stores research data from devices and uses voice-over IP technology. The in-home device used by the older person is a touchscreen computer with speakers and a handset. The user can contact 1 or more people at the same time for a chat. You can invite up to 6 people at a time onto your call. During the conversation, the screen will show who has entered and left the call. the names of the other people, and a speech bubble to help follow who's talking. People sometimes find it difficult to break into the middle of a multi-person conversation, so the Building Bridges system has an interrupt button that makes an avatar jump up and down, indicating a desire to speak. Building Bridges users can also send short messages to the other people using a simple touchscreen keyboard. As well as sending greetings and personal messages, this helps with scheduling calls and leaving messages for people when they are not online. The Building Bridges system also offers the opportunity to listen to radio or video programs, potentially provided by external organisations, such as a healthcare provider, entertainment channel, church or active retirement group. Broadcasts are played several times a day. These include such things as the news, documentaries, stories, music and health-related broadcasts. The user can view a screen that lists upcoming broadcasts. When they see a live broadcast they are interested in, they press the screen to join and sit back and to listen. During the broadcast, the user can see who else is listening. Once the broadcast is over, an automatic 20-minute conference call is created, so all they need to do if they want to join a discussion is lift the phone handset and have a chat with the group. The tea room is a chat room that is open at all times, day or night. Up to 20 users can enter the tea room at any time and chat with any other people who happen to be there. The tea room also provides a window onto the world. This is linked to web cameras in various outdoor locations. A PC-friendly client version of the Building Bridges software has been developed to extend the usage of Building Bridges. This means that the older person can easily add people, such as family members, friends and neighbours, to their contact list. When the system is not in use and enters sleep mode, it doubles as a digital photo frame. Family members and friends are able to send digital photos which can be displayed on the system. The concepts and interface design have been developed through the ethnographically informed, user-centred design approach, which is a hallmark of the TRIL Centre research programs. Potential users have been involved in each step of the development, working to ensure the system is simple and easy to use. This has helped develop a system that is well suited to older people who may not be familiar with computers and who may benefit from increased social engagement. A device that helps build bridges between older people, their family and friends, their health and social systems, and their communities.
So finally, what makes TRIL different from other centres? We are truly multidisciplinary. We have strong links with clinical centres and networks. We have a novel, very rich biopsychosocial data set of ageing with an access to a large cohort for evaluation. We're not doing technology for technology's sake. We're grounded in clinical efficacy and outcomes. We have a scalable, reusable technology platform, and we're taking experiments out of the lab and into the homes of older people. Thank you.